Hello, and welcome to Hard Conversations. This is a podcast about male sexuality, intimacy, and sex positivity, where we unpack the taboo topic of erectile issues in a safe, non-judgmental space. And now, here's your host, sex therapist, Timothy Norton.
Welcome to Hard Conversations. My next guest, I'm very excited about, Stephanie Prendergast, is a pelvic floor physical therapist and the co-founder and co-owner of the Pelvic Health and Rehabilitation Center, the largest multi-center clinic in the United States dedicated solely to the management of pelvic floor disorders, helping women, men, children, transgender, and gender non-conforming persons optimize their pelvic health. Stephanie was elected to the International Pelvic Pain Society's Board of Directors in 2002, and in 2013, she was the first physical therapist to be president of the society. In 2013 and 2015, she served on the program committee of the World Congress of Abdominal and Pelvic Pain, and 2017 served as the scientific program chair, bringing the World Congress to the United States. She has authored numerous publications in peer-reviewed journals and textbooks and regularly lectures at medical conferences and in the community on pelvic health-related topics. She is an advocate for people with pelvic pain, pelvic floor physical therapists, and the field of pelvic health. She is a co-author of the popular book Pelvic Pain Explained in 2016. PHRC publishes an award-winning blog, As the Pelvis Turns, every Thursday. Thank you, Stephanie, for joining me. Thank you very much. What is CPPS? What does that even stand for? And what's the difference between CPPS, prostatitis, and pelvic floor disorder?
Coming out hard.
Let's get into it.
CPPS stands for chronic pelvic pain syndrome, which is a term that I don't necessarily enjoy because it implies that this is a problem that's chronic, meaning it's going to be with a person for the long haul. What it refers to is a musculoskeletal condition where the pelvic floor muscles become hypertonic and can cause symptoms of urinary urgency frequency, penile pain, scrotal pain, perineal or anal pain, post-ejaculatory symptoms, and erectile dysfunction in men.
Okay.
So it is different than prostatitis in that those terms were overlappingly used interchangeably and incorrectly for a period of time. The term prostatitis implies that there's inflammation and infection of the prostate. And while the symptoms of an actual prostate infection mimic the ones I just described, it actually happens in the absence of infection. So commonly, men with these symptoms are often misdiagnosed with prostatitis and being prescribed antibiotics, when in fact it's actually a musculoskeletal disorder.
Okay, that's prostatitis. Now, what's pelvic floor disorder?
So the pelvic floor muscles run from the pubic bone to the tailbone. Most people think of them in terms of childbirth and in women and of do your Kegels, but obviously men have pelvic floors too. So it's responsible for helping with urinary function, sexual function, and bowel function. And once things become dysfunctional, as we just mentioned with CPPS, then you can have a whole host of symptoms in any of those areas. The muscles are very important to support our organs and to help keep our body functioning normally.
Okay, so let's talk about those symptoms, because I suppose I should mention that in therapy, I'll occasionally see somebody who's been diagnosed with any of these things, and the symptoms that I hear are burning, numbness, dripping, leaking, painful urination, painful ejaculation, tingling, aches, and the state of being hard flaccid. So which symptoms correspond to which, or can we even delineate that way?
So CPPS encompasses all of what you just said.
Okay.
So it's this really broad umbrella term that is it's defining a syndrome more than a specific disease. And that's important to make a note of, that this is a cluster of symptoms that can manifest with some of the symptoms you just mentioned, or unfortunately, in some cases, all of them. And so the symptoms can range from dull or achy to severe stabbing, shooting, debilitating pain.
Wow. And there's a difference between something that is a functional problem versus a pain problem.
Correct.
Okay.
So functional problems often precede the pain issues. So men may start to notice all of a sudden their urinary stream is a little bit different, or if they try to start their stream, they may have hesitancy where they didn't before. They may notice their stream diverts to one side or the other. They could have trouble evacuating stool. And then sometimes as that goes on long enough, unchecked, then it can proceed into a pain issue where then they start to develop pain again in the penis, scrotum, perineum, or anus as well.
Okay. And yeah, I love the formality of the language, evacuating stool.
You look very amused right now.
Right. So
you have trouble pooping.
You have trouble pooping.
Yeah.
But I suppose that in that situation where we're talking about these very intimate areas, that it helps to stay very formal and clinical and medical about all of these things, because not many people get to see guys in that state.
We have different language for sure.
Yeah. And so tell me about that state. Tell me when somebody comes in and they're trying to figure out what's wrong. Well, why do I have this burning, or what's wrong with my poop? What do they actually go through?
So it's unfortunate because most men have been through at least 5 to 7 providers before they typically get into our office and actually understand what's wrong, which can come with a fair amount of trauma because people are saying you just need to take this antibiotic or there's actually nothing wrong with you, when in fact they don't feel like anything is normal. So by the time sometimes they get to our office, they are extremely distressed, and at least the first day, hopefully we can do is normalize their symptoms. And they are not alone. These symptoms affect 1 in 10 men. Symptoms start as early as the 20s and 30s. They can progress into the 40s and 50s and 60s as well. But there's a whole host of issues that can affect men from the time they're 20 to the time they're 70. And it just isn't as talked about in the mainstream as female pelvic health issues.
1 in 10 men.
1 in 10 men, studies have shown, have the symptoms of CPPS.
Wow.
Mm-hmm.
If you think of something like schizophrenia affects about 1% of the population, maybe 2, maybe depending on how you count it. This is 5 to 10 times more common than that. Yet, until I started to get into this work, I never had heard of that. And I think I told you one of the times where I was talking to you about this, that I met a nurse who dealt with female pelvic pain. I think she worked in a urologist's office and didn't know men had this. Mm-hmm. So it's really not talked about much.
It hasn't been in the past. So it's great that you're doing podcasts like this to help get the information out there, because men may be listening to this and thinking, oh, I've noticed that I have these symptoms. And in a lot of people, it can be a very insidious onset. So as I mentioned, you may start to notice it's hard to start the urinary stream, or you notice you have a little bit of post-void dribble. There's another word, another medical term, like you're still dribbling a little after you urinate. And then all of a sudden you start to notice you may have tingling at the tip of your penis after you ejaculate, or something more significant. In men, a lot of times some of these things can be triggered and exacerbated by things like exercise, such as cycling or certain workouts. So they may notice that after they go to the gym, they have trouble with urination. But if they don't go to the gym, they don't have those issues. So it's starting to show that there is a functional problem that's tied to their musculoskeletal health that's creating these symptoms.
So another word that I've heard thrown around, or no, let me back up. So I was asking, what's it like when they get to your clinic?
So once they arrive at our clinic, we will go through a comprehensive history to understand how the symptoms started. And a lot of times we may be asking questions that they may not even realize are tied to their symptoms. A lot of times people do think it's an infection or an STD. So once they've been cleared for that, it usually is left in the musculoskeletal department. After we go through the history and answer any questions that they may have is the physical examination. At that point in time, we will examine the muscles, connective tissue, and joints, basically between the ribs and the knees, depending on the etiology, and also do an internal pelvic floor exam, which is done transanally. At that point, we are checking for motor control. Can people contract their muscles? Can they relax their muscles? We're looking for pain, tenderness, nerve sensitivity, as well as just overall function of the pelvic floor. That's the passive part. If there is a biomechanical cause for people's symptoms, which is often the case with male pelvic pain, then we also need to see how they're moving, what happens during various movements, during various exercises, things that will normally provoke their symptoms.
Okay. And let's get into some of that. There's a limitation for this being a podcast, and we can't show people a diagram of that area. But can you describe, like, let's say a listener at home is going to try to figure out their pelvic floor and where everything is. Can you give us the geography of these areas?
Mm-hmm. So a simple thing that people can do is when you cough, reflexively your pelvic floor muscles contract. Otherwise, you would leak urine. And if you think about trying to pay attention to the area between the scrotum and the anus, when you cough, you may feel that. So those are the muscles that do compromise or that are pelvic floor.
Okay. Right there. That it should be, what should it do when you cough?
When you cough, you should feel a small contraction.
Okay.
And when you orgasm, that's a rapid muscle contraction, which is also a pelvic floor muscle function.
In the same area?
Same area.
Okay, great.
And when you have a bowel movement, you're relaxing your pelvic floor muscles. So that's the opposite of the cough. Everything has to relax to be able to evacuate stool.
Okay.
You never think about it because your
I
body
never
just does it.
No.
Right.
And the other day, somebody told me, we were talking about relating their anxiety to these issues. And she said the moment she had some breakthrough about one of the major sources of her anxiety, that the moment that she had that realization, her pelvic floor relaxed. And I thought, how do you know? How do you tell? But okay, so it's kind of like having just avoided stool.
Right.
Okay.
But if you, just like you mentioned, if you don't think about it, these muscles are going to function on their own.
Right.
And that is what makes them different than other parts of the body. You couldn't make a fist without voluntarily thinking to do so, but your pelvic floor always maintains some tone because it's a little bit different than every other skeletal muscle in your body because it has some autonomic function. It's the same thing as your diaphragm. You can choose to breathe, and you can choose to breathe faster or to hold your breath, just like you can choose to squeeze your pelvic floor or relax it. Or if you don't think about it, it's going to do what it normally needs to do without your conscious attention.
Okay. And so you're examining somebody from the knees to the ribs. Where and who are these people?
And what are we doing exactly?
What are you doing? Yeah.
So, I mean, the passive part of the exam is palpation, and we are literally touching each of the muscles that attach to the pelvic girdle, the connective tissue, as well as peripheral nerves, looking for tenderness, pain, if the muscles can contract, if people can control them. And the same thing happens internally. So the first part of the exam, people are laying on the table, and that may be the first few appointments, especially if they have pelvic pain, until we can do the manual therapy, which kind of mirrors the evaluation to help the muscles get back down to normal tone.
Okay. And then, as you said, manual evaluation, you gestured. So can you describe the manual evaluation?
I guess you could think, I mean, it's hard. It's not as general as a massage, but it looks somewhat similar to that in terms of evaluation and treatment.
Okay. And so how invasive is it?
In my world, I don't think it's invasive at all. But
Okay.
in other people who may not be used to a physical therapist using a gloved finger to examine the muscles of the pelvic floor through the anus, that may be considered invasive.
Okay. But that's what's literally
But that's how we
happening
have
here.
to get there.
Like gloved finger, lubricant, and
one finger
right.
while people are lying down. So it's different than a prostate exam where men envision bending over the table, turn your head and cough. That's not what we do.
Right. Right. Because you're not even necessarily getting to the prostate.
We actually can access the prostate, but it's not necessary for the evaluation that we're doing. We're examining the muscles which actually surround the prostate.
Okay. And I've heard of this thing called a wand used in treatment. Do you use a wand?
Not really.
Okay.
So a wand is a therapeutic tool that people can use at home for therapy to try to mirror what may go on in pelvic floor physical therapy. I have very mixed feelings about them. I find it's difficult for patients to actually use them on themselves in a way that's effective. I would rather have them spend their time at home doing something that we know is going to help their problems, such as meditation or things like that. Whereas using a wand is, I think, rather difficult to access some muscles and successfully treat them.
I feel like I've heard of a wand gone wrong story or two. You can hurt yourself.
The anus is a vacuum, too. People need to know that. So if they're using something that isn't long enough in length, yes, we've had stories where people have accidentally sucked up the wand and has needed surgery to get it back out. And also people can press on structures that are sensitive that you shouldn't be pressing on with a wand. And I feel like the layperson really has a hard time telling the difference, even with instruction.
Okay. So use at your own discretion.
Use at your own discretion.
Or maybe just don't use.
Or maybe don't use.
Okay. I've heard, and the other question that I had was pelvic floor therapists. What kind of training do they have and what's their background?
So pelvic floor physical therapists have their physical therapy degrees. They are state and federal certifications. Beyond that, it gets a little dicey. So there's a varied amount of educational experience between pelvic floor PTs. Typically, because this is not yet taught in graduate schools, it's all postgraduate education, which means that the person people may be going to see for pelvic floor PT has really sought out additional advanced training on their own to be able to treat this patient population. And that can come, there's really no standard of care at this point in time because it's a fairly new field. So there can be a range of experience among providers.
Okay. And you guys train?
Yes. So as a company, all we do is pelvic health. So we obviously train our employees and we teach classes to other pelvic floor physical therapists to be able to do the same thing.
Okay. And I feel like so we didn't say this. This is mine and Stephanie's second take at this interview. I had my first hard conversations, impossible conversation. I had a major technical malfunction. But the last time that we talked about this, we somehow stumbled upon the fact that it's difficult to train this because there aren't that many men in the field and they're practicing on each other.
Mm-hmm. So the training that pelvic floor PTs undergo is in, as I mentioned, postgraduate classes. So what that consists of is a 2 to 3 day course where they usually have to travel and learn the didactic information, but also there's a lab portion where people practice on one another. And there's very few men as providers that are in this field, which means often women are trained by practicing on other women, which is clearly not the same thing, which is why I'm glad this podcast is happening, because a lot of men may not have access to people who can help them, and it really does require specific training to be able to do so.
Right. And so in those classes, weren't you saying that they'll actually hire not actors, but people to come in to be subjects for that training?
No, they actually do not most cases,
okay.
And I think they need to.
Okay.
Because as a female physical therapist who's about to treat this patient population, it's very difficult to take book knowledge
right.
and then translate it into the clinic and know what you're doing with manual therapy and treatment plan progressions and those types of things.
Yeah, definitely. Yeah, you would want to know. I mean, you're asking the question. So how many men's butts have your fingers actually been in?
Mine a lot. 18 years of a lot.
18 years of a lot.
But I actually was trained by a urologist on actual male patients. So my experience was quite different than many.
Okay. So another word that I've heard thrown in the gamut is pudendal neuralgia. So where does that fit into all of this?
Carpal tunnel of the butt and penis.
Okay.
So that basically means tingling, shooting, stabbing pains, just like you think of in carpal tunnel of the wrist. But that can occur, again, in all the territory of the pudendal nerve, which is the penis, the perineum, and the anus, the majority of the pelvic floor muscles, part of the urethra, and part of the rectum.
I guess you just have to go to you to keep all of these things straight.
Well, if you notice that you have those symptoms, I think men primarily go to the urologist first. If they're not familiar with the diagnosis, I would seek a second opinion. I can provide resources for medical providers across the country who are trained. But I don't want patients to feel discouraged if their doctor doesn't actually understand what's wrong with them at first, because as physical therapists need specialized training in this, so do physicians.
Right.
And unless they're seeking this information out on their own, they're probably not exposed to these syndromes or the fact they can even happen. So it's pretty easy to diagnose. The clinical symptoms are what we just said. There's no further diagnostic testing that can confirm or refute that that's the problem. It's completely based on symptoms.
Yeah, and that's a challenging factor as well. And I got to imagine there are other diagnoses that trickle into this diagnosing process.
So CPPS technically encompasses pudendal neuralgia, and pudendal neuralgia encompasses CPPS, which again is chronic pelvic pain syndrome. It overlaps with what's called prostatitis and basically the whole umbrella of male pelvic pain.
Okay, but are there other disorders that are thrown out there, other names of other disorders that you're hearing that other urologists have said?
Sometimes they will say interstitial cystitis,
Okay.
which is technically what was originally thought to be a bladder syndrome, but we now know the bladder is the victim, not the cause, an overlapping musculoskeletal condition.
Okay. Interstitial cystitis. For all of those of you Googling all these things out there, or just IC among friends. So let's segue into sex here. So how does CPPS affect sex?
So it's unfortunate because one of the primary symptoms of CPPS can be post-ejaculatory pain, erectile dysfunction, just genital pain in general. And when people have pain, it can affect desire, obviously, but also if what's supposed to be pleasurable is associated with pain, it's very difficult for our male patients, and they're just uncomfortable and they're upset and they're stressed about it, understandably.
Yeah, and then they come in and they talk to you about their sex lives.
Right. And often relieved that their partner isn't having an affair, as unfortunately men may think, because it feels like an STD. And it's not.
Yeah, I suppose we should say that there's a good chance that it's not an STD, guys, or not an STI. So get this checked out, or you get tested for the STI first, and then when that's ruled out, you're really in this territory. So you mentioned erectile dysfunction, and for those of you who listen to every single episode and memorize my words, I'm pretty careful about when I say erectile dysfunction and when I'm talking about erectile issues, because we don't want to call like anxiety a dysfunction, because if your body's in a state of fear, it's not a dysfunction. It shouldn't be hard. Your penis shouldn't be hard. But we're actually talking about something that's physically wrong. And so I would put that under the umbrella of dysfunction. So what exactly is happening to your pelvic floor that makes it so that the penis isn't retaining blood?
And I think you did bring up a good point, too, about the words and the language. Like, it's easy for me to say erectile dysfunction, but I think it'd be better to say transient erectile changes. Just like I don't like chronic pelvic pain, it should be persisting right now. Because I don't want people to feel limited that this is stuck with them for a long time. But what
Transient erectile changes?
Transient erectile issues.
What's the best acronym? TAI?
Well, I just want people to know it's a transient thing. Like this, just as quickly as it showed up, it can also be treated.
Right.
And that's where I think people they're just not informed enough. With what you read online, this looks like a pretty dim situation. But as we mentioned, the pelvic floor muscles are responsible for orgasm function. And as we discussed last time, they're also responsible for maintaining an erection. So they help to close the blood vessels to keep blood in the penis during erectile function. And if the muscles are too tight to effectively do that, which happens in pain syndromes, or if they're weak, which can happen in older gentlemen after things like prostatectomy surgeries, thinking of the whole gamut here, it's going to be a challenge to maintain the erection that isn't just the vasodilation factor and things that people think of when they take Viagra and Cialis.
Right. So if they're too tight, then blood's not going to get in there in the first place.
Or it's harder for the muscles to effectively contract to keep those vessels closed.
To keep them.
It's like trying to clench your fist when you're already in a tight-fisted position. You can't go any further. So they're just not functioning efficiently as they could.
Okay. And you can help with that.
And we can help with that. So we will examine if the muscles are too tight, which again is usually the case in pelvic pain syndromes. Manually lengthen the muscles through weekly physical therapy sessions. Typically 8 to 12 visits is standard for shorter term duration problems. And then teaching the patients how to actually regain control of the muscles themselves to maintain what we did in the clinic.
Okay,
On the
great.
latter end of the spectrum, if they have weakness or issues following prostatectomy procedures, and it's the opposite. We're actually teaching them how to strengthen and again, teaching them control, but the treatment is exactly the opposite. We're trying to uptrain everything.
Okay, and that's a huge difference.
Huge difference. It's important to know the difference as well. Yeah.
Is there another version of a cough test that they could do at home right now to have an idea if it's strengthening or relaxing?
If men try to squeeze their muscles or hold back gas, if you will, and you feel like you actually can't do that, you might be weak.
Okay. Oh, okay. So if you can't hold in your fart,
Right.
then you've got you might have a condition that could improve with this kind of treatment.
And in the later decades of life, and especially after prostatectomy, pelvic floor dysfunction affects about 80 to 90% of men.
Okay. You work on this with older gentlemen as well. And can they see improvement?
Yes. So research has actually shown that if you are undergoing a prostatectomy surgery, men have less chance of stress incontinence and erectile dysfunction if you go through pelvic floor physical therapy before and after. So I think a lot of people aren't prepared for exactly what I just said: stress incontinence, leaking urine, and erectile dysfunction. And as people live longer and the age where these surgeries are happening remains the same, people want to preserve their sexual function. So it is an easy, low-risk thing that should be part of every man's treatment plan, and it isn't always, which
Right.
still surprises me now.
Right. And
Yeah.
and as you mentioned earlier, Viagra isn't going to fix this situation, even an older man. If the blood has no way of holding itself in or it being held in, then the Viagra can't help.
Correct.
Okay. So yeah, that is surprising. Why
I mean,
don't
if you
more
think
people
about
know about you?
ankle surgeries, knee surgeries, you have to do physical therapy afterwards. Think of how much more complicated the pelvis is. Like the fact this isn't integrated into some of these things really does surprise me at this point in time.
And did I hear at one of your lectures on all these issues in women that there are countries that mandate physical therapy before and after pregnancy?
Yes. Yes, absolutely. And prostatectomy as well, but our insurance system runs a little bit differently here in America.
Prostatectomy as well.
Yes.
Do you remember which countries?
Mostly all of them that have socialized medicine, because the cost of people continuing to go to the doctor and continuing to need another surgery or another procedure far exceeds the amount of pelvic floor physical therapy. So if you think about it that way, it actually lowers cost in these other countries where medicine is socialized. Whereas in the United States, it's almost viewed by insurance companies as one more thing they don't want to pay for. So it's a little bit of a political situation there.
That could be a whole other conversation about the medical system.
Yeah, don't get me started.
Okay. When that physical therapy has actually taken place, what are guys telling you about how their sex lives have changed?
They're actually quite happy with a few visits and learning how to control their muscles and regain function. There can be quite a dramatic change, especially, for example, if you're leaking urine. You may not want to leave the house. You may feel socially isolated. And again, these people are in their 50s and 60s. This is a problem that this is happening at this point in their life, and that they can also maintain intimacy with their wife. So there can be things like Viagra and Cialis. There can be injections that they have to administer themselves into the penis. But if the pelvic floor muscle function makes up at least 50 to 60% of that, it makes sense to maximize that to reduce these other interventions.
Right. And what about the other symptoms? When somebody's had a burning for a while, one I've heard a few times is the sensation of a golf ball in your butt.
So switching back to the more younger end of the spectrum,
Right.
Obviously, if those sensations are there, it's unpleasant. And so over the course of time, we're able to help reduce them. It doesn't feel like there's a golf ball in the butt anymore, which can be a sign of pudendal nerve issues or pelvic floor muscle dysfunction.
Okay. And then they come in and they say, gosh, I'm feeling a lot better.
They can. And it's often if the symptoms are very severe, because we're talking about a whole range of things. So on the pelvic pain end of the spectrum, it is an interdisciplinary approach that's the most helpful for our patients with severe pelvic pain. So that involves medical management, which may include some pharmaceuticals that are not antibiotics, more neuropathic drugs. There can be various procedures such as Botox or nerve blocks that can be therapeutic in conjunction with physical therapy.
Okay. And once you said interdisciplinary, I got
That
excited.
means doctors and physical therapists, psychologists are all involved to help people function better in the face of their issues.
And so when would you involve a psychologist or a mental health therapist, sex
So
therapist?
at this point, I mean, for me in my career, I feel like we can kind of assess how distressed people are about their symptoms. I mean, obviously, this is unpleasant for everybody, but you can kind of gauge how people are coping or not coping. And at the point that we obviously suggest people like you, we want to have them establish a relationship with us so we're not offensive, which some people can take this as I'm only upset because I have a physical issue. But that's okay. You're just not coping well while you have it. And maybe we can help you make this less sufferable as you're going through the process. So I think in an ideal world, mental health specialists would be involved from the beginning. Our society doesn't totally work that way. And some people definitely need it more than others.
Right. And what I find is that the anxiety, the stress, the lack of coping exacerbates the symptoms.
Of course it does. So people think they're doing this to themselves because stress makes all musculoskeletal pain worse. And that's just not the case, especially if you've been told by 5, 6, 7 doctors that there's nothing wrong with you or the medications they're prescribing isn't working. You Google your symptoms, you read online that you're going to have this chronic condition that affects your sex life for the rest of your life. You're not going to be happy. That's okay. We have to sometimes undo all of that misinformation because treatment is available. It is effective. It's just not readily available to every provider across the country.
Right. And I bet some of your interventions are actually pretty similar to some of mine, like stop Googling.
Yes.
And sometimes stop examining your penis once an hour. And Dr. Gonzalez actually was saying some of those things, like we would get continual calls from people about just with the same questions over and over again, and clearly way too in their heads about it, and thus increasing their stress, and thus leading to probably more tension in the area, more tension throughout their body, and worse symptoms.
It sounds like you're in this situation and you're going to be here for the next 40 years. And people often think, oh my gosh, if I feel this bad now, how bad is it going to be then? And we do want to stop that thinking because that's just not how it has to go.
Right. And you're sitting there telling them, okay, stop thinking like that. We see a lot of results. We see a lot of progress in this area. And I know you've gotten mixed messages, but this is something that we're really good at treating. And I bet that you have to have a pretty good bedside manner as you talk to these guys.
Yes. I mean, I understand if I Googled these same symptoms and I thought I had this, I would be probably in the same boat.
Yeah.
So I understand.
But you could also read your book.
We can. And they also, it's so funny how often men see so many men coming in and out of our office. And one thing they say is everyone here looks so normal. I'm not sure what they thought, but of course they look normal. And there's so many men in here, which is true. I mean, this is not a women's issue.
Yeah.
Yeah.
Should they buy your book? What's in your book? Is everything that we just talked about in your book?
Yes, the book contains a more detailed explanation about the specific musculoskeletal issues that happen. But more importantly, my book isn't do this stretch, do that stretch, because everybody's symptoms are totally different and so are the reasons for it. It's more teaching people how to understand how they develop the symptoms and how to navigate the treatment process, because some people may need physical therapy and pudendal nerve blocks, and some people may not even need physical therapy. Maybe they need psychology. So it's really important to understand where the person is and how to troubleshoot things if they plateau or if they can't tolerate certain treatments or medications. It's really about teaching people how to think through this issue versus just go stretch your hamstring, because that's very rarely effective.
Is there a do this stretch, do that stretch book?
Well, books, yes. No, there's a ton of books saying stretch this, do that, and I don't find them very effective.
Okay.
I went for strategy.
Right. Okay. Because there are a lot of pelvic pain books out there, but you don't have one that you love.
No.
Okay. All right. You heard it here first. Now, we have talked a little bit about medications, and that's another thing that I've heard. Well, here's a typical story is, somebody told me I had prostatitis, and they, it was a urologist, gave me an antibiotic. Everything was working well for a few days, and everything came back. And now they want to give me another antibiotic, and then I found you.
So I'm glad you brought up the antibiotic situation. This is important, and everyone needs to know this, that there are analgesics in a number of antibiotics.
What's an analgesic?
Analgesic is it's Tylenol.
Okay.
Pain numbing medication, because oftentimes people with infections have pain associated with infections. Infections are unpleasant. They usually hurt. And so people can erroneously think that the antibiotic is killing a bacteria because they feel better on it, when in fact they're taking a pretty high dose of Tylenol with the Cipro, for example. And so they may feel better, and then they think their infection came back when they go off of it, when in fact they're just not taking that much of the Tylenol anymore. So many people don't realize that, and that's important to know, especially if they're given antibiotics without proper testing. To diagnose prostatitis, you have to undergo a full semen analysis, not a urine culture, but a full semen analysis. And many people who are diagnosed with that have not been through that process. So,
You're right. I'm telling you, you're right. The few times I have worked with somebody who said they have prostatitis, I asked that question, and semen analysis isn't that common.
right. And that's because it's difficult to do, and there are issues with the labs. It's just not always a clear cut and a straightforward test as we want it to be. There can be false positives, there can be false negatives. It can get contaminated quite easily. So people don't bother. They just give the antibiotics, but that's actually not right, especially time and time again. It can cause gastrointestinal distress and a whole host of other problems for men.
Antibiotics are not the only medications I've heard prescribed in this arena. What else is being given to these patients?
So because this is a pain syndrome, they're often given the same medications that are used for any type of pain, whether it be a migraine or back pain or things like that. And there's 3 classes of drugs that could possibly be effective. Those are either tricyclic antidepressants that are used at a dose lower than treating depression to treat pain. There's SNRIs, such as Cymbalta, have been shown to have musculoskeletal pain reduction effects. And the 3rd class of drugs are the neuromodulators, which are Lyrica and gabapentin. So those drugs may be prescribed for this just as they are for any other pain syndrome. And depending on how involved the nervous system is or isn't in somebody's issues, they can be effective or not effective.
That's interesting, because when I took my licensing exam, I learned about all 3 of those medications. And so those must be secondary benefits to those medications? The SNRI wasn't designed for pain.
No, but it has been FDA approved for pain.
Okay.
Whereas the tricyclic antidepressants and the neuromodulators are off-label uses.
Those are off-label uses.
Actually,
okay.
the tricyclics may be on-label at this point.
Okay.
But Lyrica and gabapentin are off-label for pain.
But really commonly prescribed.
Commonly prescribed.
Okay. And how do you feel about all three of those drugs?
I think for certain patients, some of them have been quite effective. I think the side effects can sometimes outweigh the benefits. The most important thing with the medications is that patients often don't understand why they're taking them, and they have unrealistic expectations as to what they should do. So if you take these medications and you have daily unprovoked pain, it's not going to take it away, but it may take it down a few notches. So if you can't sit for more than 10 minutes without getting severe perineal burning, maybe instead you get perineal aching at 15 minutes instead of 10. And that actually is considered effective for what it's intended to do, but people think it's just going to completely take away their symptoms, and that's just not how it works.
Right, because I'm thinking about the way that study would be designed to study the efficacy of that medication, and that is an improvement.
That is an improvement, but
Yes.
this may be why it's not FDA approved for pain. It's very difficult to quantify.
Right. Okay. Yeah, because I would imagine I'm prescribed a tricyclic, and I go home and I Google that, and I'm like, wait a second.
I'm not depressed.
I'm not, well, am I depressed? Because I'm certainly very distressed about this. So are they saying that if my depression goes away, that this pain's going to go away?
Right. So I think, again, people think that they're given it because they're being told it's all in their head or things like that, because often physicians may not have time to explain why they're giving patients these drugs. So they are meant to treat pain at different doses than for depression. It's important to know. For the tricyclics, Cymbalta is the same for anxiety, pain, and depression, and that can be an effective medication to help people go through the treatment process.
Okay. So I'm trying to imagine the guy who has some of these symptoms, who's kind of a long way from deciding, okay, I'm going to come in. What can you say to him? Is there a video where he could look online and say, okay, I just want to see what this is like? Or is there something that might kind of make it hasn't been in a movie?
Not yet.
Okay.
It's creeping into movies for female pelvic pain and TV shows and all kinds of things right now. No, it hasn't been in a movie. I think doing some Google searches, the lecture that you attended at USC is available online, where people talk about the whole spectrum of things. And I think for men not sure if this is what they need or not, I think an evaluation is warranted, and at least get a little bit more information. If you have these symptoms, I think you should rule in or out the pelvic floor as a source of them, so you know.
And they could come in and get a decent evaluation without getting a finger in the butt.
Nope.
Okay, so that's going to be a part of it. So
That's going to be part of it.
I don't want to say man up, but I guess I'm kind of saying that.
Well, and as the symptoms get severe enough, they rarely, once you get to a symptomatic point, they may not resolve on their own. And I think that motivates people to seek appropriate attention because they can see that things are changing and progressing and often not in the right direction.
Okay. Is there anything that people could be doing in the meantime that they're mulling over this decision of whether or not to come to your center? Are there stretches? You already mentioned maybe ease back on the cycling.
Well, and again, it's all about someone's anatomy. Plenty of people cycle and have absolutely no problems, and certain people may ride their bike a mile and all of a sudden have penile numbness for 2 days. It really depends on your anatomy and if your body can do the activity in question. And so listen to your body. If you do feel symptoms after certain exercises you do at the gym or riding your bike or sitting for 18 hours, listen to your body. Get up, move, and if the symptoms repetitively keep coming back, that activity may not be okay for you, but you also may have a treatable condition.
Are there yoga poses guys could do to help this condition?
In general, the child's pose will help relax the pelvic floor muscles. However, If you have symptoms of pudendal neuralgia or there is nerve symptoms, burning, shooting, stabbing, tingling, things that stretch muscles will also stretch the nerve and provoke the symptoms. Nerves do not like to be stretched. So it's really important to distinguish patients with nerve issues from muscle, because what you think could be therapeutic could actually be less useful. Same thing with a lot of people with low back pain. They want to strengthen their core. That's actually going to provoke your pelvic floor muscles to tighten. If your muscles are tight enough that they can't relax, things that are well intended to help your back are actually going to cause pelvic pain or exacerbate your pelvic pain. So strengthening is not always the answer in these cases until the muscles are in a position that they can do so.
Okay. I think that's a really good rule to live by. You say things that stretch the muscles stretch the nerves.
Yeah.
Yeah. Okay.
So it can be provocative instead of therapeutic.
Right.
And you'll know. It may not happen right away. It may be a delayed onset, like 2 to 3 hours. But people usually can start to tie provoking activities to their symptoms once we start asking them more specific questions.
Yeah. And that would happen over the course of treatment. They'd start to piece things together.
Mm-hmm.
I bet a lot of guys will say things like, but I've been cycling my whole life, or something like that, though, or all of the exercises. What's your response?
Well, maybe they've been cycling their whole life, but recently they had a bout of sciatica. And so now things are different. The sciatica resolved, but maybe their hip muscles are still tight, or there's still some sort of tissue change that is now causing symptoms during the same activities they've always done. And I also say your body changes over time. Like, we cannot do the same things in our 30s necessarily that we did in our 20s as much as we all want to. Things are different as you age, and it doesn't mean it's not correctable, but you may need to focus your attention on addressing impairments.
You keep mentioning studies. Has there been a really good meta-analysis, or maybe your book would just be a collection of those, or where should a guy start reading so he's just not Googling blindly about this stuff?
That's a good question. I think our blog is a good patient-friendly resource, and we reference that to go to other places. Most people don't want to read medical journal articles. However, I would say, yes, I would say that this year, just in August, Rodney Anderson published in the Journal of Urology a huge meta-analysis on CPPS. And instead of calling it a prostate dysfunction, they're finally acknowledging it as a psychoneuromuscular disorder. So affecting the mind, the body, and the nervous system. And they went through all of the literature on this, and again, showing that the majority of men never have an infection. They don't respond to antibiotics. They don't respond to a lot of medications because it's not that type of a problem. And I think that's a big step forward, because most urologists get the Journal of Urology. So even if they're not seeking out additional knowledge for these patients, this came to their doorstep, so hopefully they read it.
Awesome. So yeah, if your urologist doesn't seem to know what's going on, get the August Journal of Urology, find the article by Anderson, and this is Googleable, obviously, and you probably have to pay the $40 for the article, or there are ways around that we won't go into on this podcast. But yeah, and forward it to your urologist. Hopefully he or she will read it. And this is why these studies take place in a big meta-analysis. And that was just a couple months ago.
That was recent.
Yeah.
Big step forward, I'd say.
Yeah, that's great. And you're reading your Journal of Urology.
Must stay on top of it.
Yes, you do. Okay, so just in general, what would you like to say to the guys out there who have some of these symptoms? Like, what words of hope can you give to them?
They can and will get better. There's usually room for improvement. If you have these symptoms and people are telling you there isn't anything wrong, or certain treatments that they're prescribing are not working, I always recommend getting a second opinion. I can direct you to resources where they can find providers that are skilled in treating this. And I think that they should move forward and try to get the issues taken care of. Don't ignore them.
Great. And their sex lives can improve?
Sex lives can improve, erections can improve, anxiety can go down. You can return to the exercises that normally provoked your symptoms. All of this can get better.
Okay, good. And what about for you? What's going on in your world? You have how many centers?
9.
Wow.
Now we just opened one more.
Just opened one more, and those are not all in California.
So we're in New England, Northern California, and Southern California.
Okay. And what kinds of things do you have on the horizon?
What's on the horizon? That's a good question.
Running
right
9
now,
centers.
we're trying to hold down the fort.
Yeah.
Right now, we're pretty busy in the clinic, and it looks like in 2019 we're going to start teaching again and locally. I have a larger space now, so things will be changing a little bit on that front. Basically, just keeping the clinics running at this point.
Yeah, that's a lot to oversee, and it was you are very busy. Absolutely. It took us a while to get this rescheduled after I blew it on the first episode, but you're at the top of your field, and you're doing really great work. And every time somebody name drops you, they're saying really wonderful things. So I know I said it at the beginning of this episode that I was excited, but I am. I think that you're doing really, really important work, and I'm so grateful to have you on here and helping us have these hard conversations. Where can we find you on the internet?
Our website is pelvicpainrehab.com. Book is on Amazon. It's called Pelvic Pain Explained. And that's where we are.
Okay.
I practice in our Los Angeles location.
Right. You're on Twitter?
I'm on Twitter at Pelvic Health.
Okay.
Also on Instagram, the same, at Pelvic
Okay.
Health. And Facebook is Pelvic Pain Physical Therapy.
What kinds of pictures do you put on Instagram?
Yeah, that's a good question. We
You will
haven't
find
been
out.
flagged. Yep.
Okay, great.
Check us out. It's a challenge.
All right, Stephanie. Well, thank you so much.
Thank you.
All right, bye-bye. Thanks to the show's executive producer, Robin Morrison. Thanks to Kat Murphy, director of social media. Thanks to Team Scrub for the music. Thanks to the sound engineer, Ravi Carmen. Thanks to Brian Hui for naming the show. Thanks to Alex Pitts for the intro. Thanks to Arlene Asuncion for the logo. You can find this podcast at hardconversationspodcast.com or wherever you get your podcasts. You can locate me on Twitter at TimNortonLCSW or on my website for my private practice, timnortontherapy.com. You can also email us at hardconversationspodcast@gmail.com or call into our hotline at 662-626-4276. That's 662-MAN-HARD. Thanks to all my friends and family for brainstorming this show with me. Shout outs to the sex positive community, including sex educators, sex therapists, sex coaches, other fellow sex podcasters, sex surrogates, academics, the sexual health medical community, sex workers, the tantric community, and everybody else involved with having hard conversations. Bye-bye.